Hi class, this is part 1 of the your first COMHE 330 lecture. So this lecture is for Tuesday, August 30th. Today I'm going to be talking about the introduction to and the history of epidemiology and some dynamics of disease transmission. So first, just to get things started, everyone should have access to Blackboard. If you don't, go ahead and email me. My email's here. You also will probably get emails from my address. It's a grad center email address. You guys feel free to use either of those to contact me. So if you don't have access to Blackboard, go ahead and email me so that I know to send you I'll try send you all the course materials that you need for this week. I'm going to start by reviewing our syllabus. So really quickly, I'm going to switch screens to the syllabus, making sure you're seeing what I'm seeing. Okay, so right, so we are now going to be meeting in room 115A Tuesdays from 10 to 12:40. Again, here's my email address if you guys need to contact me. I do not have office hours set up. In the past, I've found that students aren't usually at office hours. If you want to meet with me, just email me and we can set something up. Also, I'm always happy to come early to class or stay after class to talk to anyone who has questions. This course is going to be on Blackboard. If you need any sort of support, these are the links to people who can help you. So the course description, we're going to be talking about risk factors, distribution of diseases, causes of diseases, prevention of diseases. And the format's really going to be that for the first half, I'll lecture to you guys. And then for the second half, we're going to have some in-class discussions and assignments. Some weeks I might end up having to lecture for the majority of the class. It just depends on the topic we're covering. The book that you'll want for this course is Leon Gordis Epidemiology. You can use the 4th edition or the 5th edition. Not very much has changed between those. I think the 5th edition has some prettier pictures, more color. So if the 4th edition is cheaper, go for that one. I've been going back and forth between both of them and haven't found any problems yet. The other thing is that I don't think it's that much. I checked Amazon and I think it's around $50, probably even less if you want to if you just wanted to rent it. All right, let me make this bigger, hide. Oh, wait. Sorry guys, just checking my screen to make sure we're seeing the same thing. Okay, so program competencies. All right, so and course learning objectives. You guys can go through these in details, but basically this course is about explaining epi methods to you, right? And it is very introductory. So some students think that they're going to come in and learn about diseases, and we are in fact going to talk about diseases, but this isn't a biology course. I'm not going to be going through the physiology of diseases or the biology of what's happening. What we are going to talk about is study design, statistical analysis, and epidemics broadly. And the way this is going to be assessed is through a variety of class projects. So primarily, though, it's going to be through a research project. So let me get to the course assessments. So your midterm assignment is going to be a PowerPoint presentation and a literature review. So the class is going to be divided into groups around a health topic. I'm going to put together a survey for people to choose a health topic. You can choose from the list, or if there's a health topic that you're interested in, you can go ahead and pick that health topic. Now, for the midterm, what you're going to end up doing, and again, I'm going to go over all of these assignments in much more detail when it's closer to the when it's closer to the time that these are due. But this is what it sounds like. You're going to do a lit review on whatever the health condition is you and your teammates select, and then you present it to the class. Next is the data collection and analysis. Then you're going to have to go out into the community and survey at least 50 people for your data collection assignment. And you're going to survey people about the health condition that you've selected. So if you choose depression as your health condition for the semester, then you're going to survey people about depression. So I would keep that in mind as you start to think about what topic you want to do. Some people, might be interested in doing a project on chlamydia infection, but after realizing that they actually have to go talk to people about chlamydia infection, then they change their mind about what they're going to study. The culmination for the semester is going to be a final presentation. You are going to tell us what you found in your research project. And you're also going to write up the results of your research project. So you'll present your final to the class, and then you'll write up a brief document for me to review. There also will be some quizzes, readings, some small homeworks as we go along. In terms of participation, you are required to be present on time, prepared for class, and ready to participate. So this class is really going to function as a community. And in order for this to work, you have to be willing to participate, and you have to do the readings. So be ready to engage in discussions, refer to readings, and ask questions. Half of your participation grade will be based on your, oh, sorry, this should be updated. We aren't having a morning session. But so half of your participation grade will be based on just purely attendance, right? The other half is going to be based on actually participating, and usually when I'm rating students, it's just sort of a low, medium, high in terms of participation. And in terms of whether you're giving me the impression that you've read the articles. At one point during the semester, are going to be asked to be a class discussion leader. And what happens when you're a class discussion leader is you're just in charge of walking your classmates through the articles that you had to read for the week. And a portion of your participation grade will be based on your preparation for and leadership of the class discussion. So this sentence right here, I'm going to go ahead and remove from the next update of this syllabus. This sentence that says your participation grade will be based on the morning session, that's not applicable to this class. All right, grading. Grading is standard for Hunter. So down here you see anything above 92.5 is an A. 90 to 92.5 is an A minus. Anything above 82.5 is a B. In terms of evaluation, class participation is going to be worth 10% of your grade. Assignments, so this is the homeworks, quizzes, readings will be worth 20% of your grade, and this is where the individual parts of your grade come in. So 30% of your grade is based on what you do as an individual in this course. The rest of your grade, however, though, midterm, the data collection analysis, and the final, so that 70% of your grade is going to be based on your group projects. So just keep that in mind as you're going. Sometimes group work works well, sometimes groups don't work well together. You guys can always feel free to contact me if there's any sort of group problems in terms of dynamics and working together. All right, so what else? You have the right to appeal grades. You do so through Hunter. In terms of attendance, I'll excuse up to 2 absences. Beyond that, absences and or lateness will result in loss of participation credit. So regardless of the reason for missing class time, try not to come late. So, get to class on time. And just let me know if you need to be late or if you're going to be absent for any reason. So in terms of late assignments, if you're turning something in after the due date, you're going to lose 10%. 10% of the total credit per day that it's late. So if you're 2 days late, the highest grade you could get is 80%. So in terms of extra credit, I don't offer extra credit unless for some reason you have to be gone a lot. So I will offer extra credit for participation. You know, if you get really sick and you have to miss more than 2 classes, let me know and we'll come up with a way to make sure that you're not losing participation points. In terms of expectations from students, refrain from cell phone use and personal emailing, texting during the class. If you have an emergency, always feel free to leave the classroom. Students who are going to be on their phones will lose participation credit. And the other thing is that because a lot of this class is going to be discussion, just try to be considerate of your classmates. Obviously, people will have differing opinions, and that's fine. What you can expect from me, I will always give you very specific guidelines for each assignment, and they will be provided no later than the class before which it's due. So something like your midterm, I'm going to provide to you a month in advance. Something like a homework assignment, it will probably be the week before it's due. For the main assessments, the midterm, the data collection, and the final, I will provide you with my grading rubric, what I will use to grade these assignments. Graded assignments will be returned. This says 1 week for this class because there's so many students, it's probably going to have to be within 2 weeks of submission. I will also update this on Blackboard. And especially for the main assignments, the midterm, the data collection, and the final, graded assignments will include some sort of explanation for why you lost points. The course schedule is here. So for today, we're going over Gordis, the Gordis book chapters 1 and 2. Next week, it'll be Gordis book chapters 3 and 4. And there's 2 articles on STD epidemiology to read. Those have already been posted in Blackboard for class 2. This course schedule will change as we go. So whenever I make an update, I'll put it, the most up-to-date version of the schedule will be available on Blackboard, and changes in readings will appear in red. Term will be assigned the 3rd week of class, so September 13th, and then October 25th is when you guys will go ahead and present midterms. November 1st. Usually midterms take more than 1 class period to present. The final written report will be due at the end of semester on December 13th. Okay, so now I'm going to switch back to our lecture slides for today. So today we're going to go over basic concepts of epidemiology. So in your book, this is going to be a lot of definitions, right? Making sure that we're all talking about things in the same way. And then we'll also start to go over some basic concepts of disease transmission, as well as talk about a little bit about the history of epidemiology. All right, so in terms of terminology, when we talk about endemics, this is just referring to the constant presence or usual prevalence of a disease or infectious agent in a population within a geographic area. So I think an easy way to think about this is as the baseline level of disease. So here we're looking at a graph of rotavirus. So rotavirus is a pretty common childhood infection. It results in some gastroenteritis. And what you see here from June to November, where the line is kind of flat, is just the endemic level of disease. Now, rotavirus is a seasonal disease, so when it gets colder, we usually see a peak, and that's what you're seeing here from November to May, right? So the highest peak occurring around January. So when we talk about something that's hyperendemic, it's just referring to persistent high levels of disease occurrence. So looking at the next graph, this black, the black line with black squares is all bacterial diseases. The just black line without any squares is all viral diseases. And you see with this red line, and I just put this on the graph, it's a fake uh, fake distribution of diseases for, we'll say, norovirus. And you just can see here that from May to December, it's much higher than what you would see for any other viral diseases. And we'd refer to that as hyperendemic. All right, a sporadic outbreak or sporadic disease just refers to something that's occurring infrequently and irregularly. So a small outbreak of salmonella you might refer to as sporadic. There's technical differences between something that's sporadic and say an epidemic, but for the purposes of this class, yeah, you don't need to worry about it. So occasionally the amount of disease in a community will rise above the expected level. So will rise above the endemic level, the baseline level of disease. And when that occurs, then we are starting to talk about an epidemic. And an epidemic just refers to the occurrence in a community or region illness that's in excess of normal, so in excess of the endemic level of disease. And epidemics are not limited to communicable diseases, right? We can have injury epidemics. So take, for instance, car crashes, right? At one point, there was an epidemic of injuries from car crashes, and then the public health community sort of worked to change safety laws and laws around driving. And also there's a lot of chronic disease epidemics, right? I'm sure people have heard about the obesity epidemic or the diabetes epidemic, right? So these aren't infectious diseases, but they are still epidemics nonetheless. So in 2014, West Africa experienced one of the largest Ebola epidemics we've seen in the history of the virus. So Ebola is a pretty rare and deadly disease. It's caused by 5 different Ebola viruses. 4 of the strains are known to cause illness in humans. The 5th, Reston virus, has caused illness in some animals, but not humans. So why was 2014 considered an epidemic? Well, it was the largest outbreak we've ever seen. So this image here is showing you the number of cases, we've seen since Ebola was first discovered, which was in 1976. It was discovered near the Ebola River in what is now the Democratic Republic of Congo. And since 1976, if you look at this timeline, we've seen some pretty sporadic outbreaks, right? But in 2014, we saw the biggest one we've ever had. So looking at 1976, there was 318 cases. Looking down at, or I guess still up here, 2000 to 2001 was the second biggest outbreak we've seen, 425 cases. And then if you look down here at the bottom, 2014, we have 24,000 known cases. And that was as of March of 2015. So there could have been more reported. So why was the Ebola outbreak in 2014 an epidemic? Well, I think it's pretty clear that the number of cases was clearly in excess of normal. So in the case of Ebola, one case sort of warrants investigation. But when you look at sort of the general trend, right, we had only been talking about a couple hundred cases until 2014, when we're starting to talk about tens of thousands of cases. All right, so how do you distinguish when something's sporadic versus an epidemic? Again, for the purposes of this class, I don't think it really matters, but generally when we're talking about something that's sporadic, it's just a handful of cases, right? So For instance, you might hear about salmonella outbreaks that occur. So salmonella is a bacteria. Generally people develop some sort of GI symptoms, diarrhea, vomiting, and it'll occur anywhere from 12 to 72 hours after the onset of infection. Then you'll start to get the symptoms. Now, the reason we care about salmonella is that because in some cases the condition can be life-threatening. So in 2008, there was an outbreak, 1,400 cases. The outbreak was initially linked to tomatoes, but not definitively. And what we saw is sort of people were worried about going out and buying tomatoes. And then we found that it was actually, in fact, that were peppers that were being harvested and shipped up to the States were the cause of the outbreak. Now, salmonella cases are usually regarded as sporadic, not epidemic. But in 2008, just the sheer number of cases, it was considered an epidemic just because there was more than a handful. You know, we weren't talking about 5 cases, we were talking about 1,400 cases. Now, an outbreak carries the same sort of definition of epidemic or sporadic disease, but it's often just used for a more limited geographic area. So an outbreak, say, in a small town, or an outbreak in just one community in Manhattan. So some diseases are so rare in a given population that a single case will warrant investigation. Things like rabies, plague, polio. If one case is reported, it's going to be treated as an outbreak. Other diseases, though, occur so commonly that only deviations from the norm, significant deviations from the norm, warrant investigation. So things like influenza, right? We expect a certain baseline level of influenza every year. When you start talking about things like swine flu and bird flu, then you're more likely to see the government get involved and investigate these outbreaks. All right, so looking at some common outbreaks we see, measles is a highly contagious disease caused by a virus. Symptoms generally include a high fever, coughing, a runny nose, something called the measles rash. You can Google image it if you're interested in seeing it. So as of 2000, measles was declared eliminated from the US. And the annual number of people reported to have measles has ranged from around 37 people in 2004, so way down here, to a high of 668 in 2014. Now, most of these cases originated outside of the US, or were linked to a case that originated outside of the country. But in 2014, you see this big spike here. The US experienced a record number of measles cases. So these 667 cases were from 27 states. And it was the greatest number of measles cases we'd seen since measles was declared eliminated. And these cases were primarily linked to unvaccinated Amish communities in Ohio. So I think almost 400 of the 600-ish cases were definitively linked to Amish communities in Ohio. And in fact, they were linked even further back than just being as a result of people in the Amish communities, but it was brought in from the Philippines, which had experienced a large measles outbreak the year before, so in 2013. So today we know that the majority of people who get measles are unvaccinated. So, and measles is still actually pretty common in some parts of the world, Europe, in a few handful of countries in Europe, Asia, the Pacific, and Africa. And it's generally travelers that spread measles in the US in communities where people are unvaccinated. So we also had an outbreak of measles in 2015, and this one was all over the news. So some of you may recall hearing about it. So there was a total of maybe 200 cases. Let's look back at the graph. Yeah, a little under 200 cases. And this outbreak was actually linked to an amusement park in California. And again, the outbreak likely started from a traveler who became infected overseas and then visited the amusement park while they were infectious. However, in the 2015 outbreak, no source was actually identified. So 2014 traced back to the Philippines, 2015, no source identified. One analysis, though, by CDC did show that the measles virus type in this outbreak was identical to the virus type that caused the outbreak in the Philippines. So it makes you think that potentially the 2015 outbreak could also be linked to the Philippines. And again, outbreaks, right, because they're for the most part clustered in communities. So sort of originating in California and then spreading from there. All right, so what about a pandemic? Now, a pandemic refers to an epidemic that's occurring worldwide or over a very wide area. So usually we're talking about something that crosses international boundaries and affects a large number of people. So one of the more famous ones is the 1918 or the Spanish flu. It's estimated that a third of the world's population was infected. And the case fatality rate, the reason they were so worried about this flu specifically is that the case fatality rate was so high, so around 2.5%. And generally, influenza case fatality rate is less than 0.1%. The other reason why people were so worried about this flu in particular, and this is also what we saw with swine flu and what they worry about with bird flu, is that the fatality was different. So this dashed line down here is the Spanish flu, or is non-Spanish flu. So the flu from 1911 and 1917. And you're seeing the death rate. And what you see here is that generally, in all other years before 1918, it was younger persons and older persons who died from the flu. With the 1918 flu, however, though, there's this peak in the middle, and this is why people get so concerned about swine flu and about bird flu, is because you see that young, healthy people actually have high fatality rates. So 25 to 34-year-olds, right, fatality rate, there's a peak here, which is unusual for most years of flu. And to sort of put this into perspective, it was estimated that 50 million people died from the 1918, the Spanish flu. And this you could compare to the number of people that died during World War I, which was 16 million. All right, so let's do some quick checks just to make sure all of these terms are making sense to people. If I said there was 22 cases of Legionella occurring within 3 weeks among residents of a particular neighborhood, and there was usually 0 or 1 cases, which one of these would you think it was? Sporadic, endemic, hyperendemic, pandemic, or epidemic? And if you're guessing sporadic or epidemic, I would say that's the right choice. Just as a heads up, lots of times your quizzes will look like these sorts of assessments that I put in the slides. All right, next one. The average annual incidence was 364 cases of pulmonary tuberculosis per 100,000 population in one area. Let's say New York, compared with the national average of 134 cases per 100,000. All right, what would we consider this? So here the correct choice is hyperendemic, and the reason being that the national average is 134. The incidence in whatever this one area is, New York, say, is 364, and that's almost, it's 2.5 times as large as what we see nationally. All right, next one. So over 20 million people died from influenza from 1918 to 1919 worldwide. Died. Here the correct answer is pandemic. The last one, a single case of histoplasmosis was diagnosed in a community. And this one I would go with sporadic here. Oh wait, sorry, not last one. One more. About 60 cases of gonorrhea are usually reported in this region per week, which is slightly less than the national average. Here, the correct answer is endemic, so 60 cases per week. It's not that much lower than the national average. This is just the baseline, the endemic level of disease. All right, so what is epidemiology? Epidemiology is just concerned with the distribution and determinants of health and disease, morbidities, injuries, and disability, and mortality in populations. So the focus of epidemiology is really at the population level. So this is as opposed to clinical care where the focus is on the individual. You might hear terms like population medicine thrown around when people are talking about public health or epidemiology broadly. So if you take something like lung cancer in epidemiology, you might ask, is lung cancer mortality higher in geographic areas with high pollution, right? Whereas in clinical medicine, you would just diagnose and treat lung cancer in an individual. Same with something like salmonella. So in epidemiology would ask, is salmonella infection occurring among people eating a certain type of tomato? Whereas a medical doctor would just diagnose and treat salmonella infection in an individual. All right, so distribution. Distribution just implies that the occurrence of disease, injuries, disabilities, and other conditions varies with subgroup. So epidemiologists are often identifying subgroups that have increased occurrence of adverse health outcomes in comparison to other groups. So this graph here is from New York City's EpiQuery, which you guys will be using for your midterm. And it's showing you chlamydia rates per 100,000 population. This is for 2014. I don't think I put the year on here, but I think it's the 2014 rates. And what do you see here in terms of distribution? Well, you can tell that 15 to 24-year-olds have the highest rates of chlamydia. Along with, the 25 to 29-year-olds also have pretty high rates of chlamydia, which is why these groups are targeted usually for prevention, why STD testing is recommended annually for these age ranges. All right, what do we mean when we say determinants? A determinant is just any sort of factor that brings about change in a health condition. So bacteria and viruses, carcinogens, and exposure, when we talk about exposure to some sort of disease-causing agent, that can refer to contact with the disease or health condition causing factor, or it can also refer to the amount of the factor. So, for example, and these two words, exposures and determinants, are kind of used interchangeably. Let's take smoking and lung cancer, right? So you could, but when we talk about the amount of the factor, you could smoke 1 cigarette a day. You could smoke a whole pack a day, right? There's a difference there in the amount that you're being exposed to, the amount of the factor that you're being exposed to. So you have contact with a disease or health condition causing factor, that being cigarettes. And then there's also a distinction in terms of the amount of cigarette smoke you're exposed to. All right, so outcomes. Outcomes are just the diseases or health condition that you're studying. So it's the result of your exposure or your determinant. So in that same example here, the health condition is lung cancer. You're talking about smoking as the exposure or determinant, and the health condition is lung cancer. When we say morbidity, we're just talking about illness. Obviously, with mortality, we're talking about death. So the objectives of epidemiology are to identify the etiology, or in other words, the cause of a disease and the relevant risk factors. So with the ultimate aim, and being to intervene in order to reduce morbidity and mortality. If we can identify causal factors, then we can develop some sort of rational basis for having a prevention program. Another objective is to determine just the extent of disease found in the community. So, and this is really important in terms of planning for and provision of health services. If you're, say, going to provide discounted medical drugs for some sort of health condition, say HIV, which is what happens with the Ryan White program in the city. Well, actually, the national program that tries to make HIV medicine affordable. Then you need to know how many people are living with HIV in the city, right? To make sure that when you apply for grants and apply for Ryan White funding, you have the right amount of resources. Another objective of epidemiology is to study the natural history and prognosis of disease. And again, you're doing this to start to understand etiology or causes of disease. Also evaluation. So a lot of epidemiologists sort of evaluate existing or newly developed preventative and therapeutic measures. So preventative being maybe, say, some sort of get active program, seeing if it can prevent the number of diabetes diagnoses. And therapeutic meaning more clinical measures. You know, does this new drug change the number of cardiovascular diagnoses? The last objective of epidemiology is just to sort of to develop public policy based on, you know, what we know from the distribution of the disease or the risk factors. Right. So from the 1900s, this is on the left, to 2010 on the right. We've seen a sort of shift from infectious diseases to chronic diseases in terms of mortality. And what's been the major challenge. So there was a point in time when scientists thought that infectious diseases would no longer be a cause of death. We now know that to be untrue, right? There's been a lot of zoonotic and emerging infectious diseases that still remain to be a problem. So you could think of things like HIV in the 80s, the Ebola being recognized as a new infectious disease in the 70s, or even Zika virus now, right? But for the most part now, people don't die from infectious diseases. They actually die from things like cancers and heart diseases. So in terms of prevention, again, a goal is to identify subgroups in the population at high risk for disease and direct preventative efforts. And there's a couple ways this happens. There's primary prevention, and this is taking actions to prevent development of disease in a person who does not yet have disease. So for instance, condoms prevent HIV infection, so distributing condoms would be a primary preventative measure, right? You're preventing disease in people who do not yet have disease. Secondary prevention, on the other hand, would be to identify persons in whom disease has become but who have not developed symptoms. So sticking with this HIV analogy, you would try to diagnose someone with HIV, so before AIDS develops, before the person's seeking medical care. They don't have symptoms yet, but they are infected and could go on to pass the infection on to someone else. So, but if you can diagnose them before they're seeking medical care, right, then you can at least make them aware of the condition. Tertiary prevention is preventing complications in people who have gone on to develop signs and symptoms of illnesses. And then treatment of illnesses to prevent complications. So this is like trying to treat AIDS before death occurs. Now, EPI is a population-based approach, right? You're generally trying to recommend preventative measures that will apply to an entire population. So recommending all persons wear condoms to prevent HIV infection. You can also, in terms of prevention, have a high-risk approach, and this is just targeting high-risk groups with preventative measures. So sticking with the HIV analogy here, this would be like recommending PrEP for HIV prevention to communities at risk. And for people who don't know what PrEP is, it's a pill that you can take once a day that lowers the likelihood of you acquiring an HIV infection by around 93%, they think. So you can think of it like a birth control. It's one pill you take a day, but it's not recommended for the population. It's recommended for people that are at high risk of acquiring HIV. So someone who is in a serodiscordant relationship, serodiscordant meaning one person has HIV and the partner does not and wants to prevent themselves from getting it. So in terms of the way an epidemiologist usually works, there's kind of a two-step approach. First is to determine if an association between an exposure and disease exists. So say some sort of environmental agent and lung cancer and lung diseases exist. And the second step is to determine if the association is actually causal. So first step being to understand if there's just if there's a relationship there, and the second step being to understand whether or not it's causal. So a risk factor is an exposure that is associated with a health condition. So you could say sex without a condom increases the risk of pregnancy, chlamydia, HIV. Poor eating increases the risk of obesity, cardiovascular disease, and risk assessment is really a cornerstone of epidemiology. And epidemiologists will use the term risk factor to indicate that an exposure is associated with an outcome. And what you guys this semester are going to be doing is risk factor epidemiology. The thing to keep in mind here, and why this is the first step, is that a risk factor is not necessarily causal. So causality is very difficult to prove, and we're going to have entire lectures where we just talk about how you determine something's causally related. So we know that HIV causes AIDS. And the reason this matters is that if we can determine which risk factors are causal, then we may be able to intervene on the right risk factors and decrease the chance of illness in the community. So, and because you don't want to direct resources in the wrong area. So things like gray hair is associated with Alzheimer's, right? If you were going to look at the statistical relationship between having gray hair and having Alzheimer's, you would see that there is an association there, because who has gray hair? Old people have gray hair. Who has Alzheimer's? Old people have Alzheimer's. Are they causally related? No, definitely not. But they are correlated. So again, a really important thing to keep in mind this semester is that correlation is not causation. And some other examples, good examples, I think are, female gender and depression. Are females, is being female going to cause someone to be depressed? No, but we do know that females go to the doctor more often. So it often will look like females have more depression. Epidemiology is an observational science, and what that means is that we observe situations. So we observe if there's a relationship between smoking and lung cancer, if there's a relationship between eating peppers and developing salmonella. And there's sort of two branches in epidemiology. So there's descriptive epidemiology, and this is just characterizing a health condition in terms of person, place, and time. So for example, I showed you chlamydia trends by age groups in New York City. That's just descriptive epidemiology. Now, analytic epidemiology, which is what you'll be doing this semester, is examining actual associations between exposures and outcomes. So let's say you pick depression as your health condition for the semester, and you wonder if the number of classes a person takes is for some reason associated with being depressed. Now you're looking for an analytic association between a risk factor and the outcome. And this is what we refer to as analytic epidemiology. Right, so I'm gonna pause the recording here and then start. I'll stop here and pick up here with part 2 of the recording.